Do I want to say anything else about this slide? Let me just keep going. So then the next issue, of course, is the risk of the medications to the fetus and the risk of seizures to the fetus. And it's a whole balancing act about deciding what's riskier, having a lot of seizures while you're pregnant or being on medications or more than one medication while you're pregnant. So when someone has a generalized tonic-clonic seizure or a grand mal seizure, there are risks to the fetus, mainly to do with lack of oxygen and acidosis, which basically means like the blood in the mother becomes more acidic, and this could be a risk to the baby as well. There's an increased risk of abruptio placenta, so like the placenta dislodging and bleeding, miscarriage, stillbirth. Also, if you fall when you have the seizure, there could be trauma to the baby or to yourself, and hemorrhage to the baby from the trauma of hitting the ground. So those are the main risks of having a big seizure. Now, complex partial seizure, absence seizure, if you're just staring unresponsive, probably in itself does not have any risk to the baby. It would be mainly if you had an accident while it was happening, like, I don't know, if you tend to fall over or if you are in a bad place when it happens, you know. But just those staring spells probably in and of themselves aren't dangerous to the fetus. So if someone has epilepsy and they want to get pregnant, when do we change the medication or decide if a change should be made? So if you're thinking you want to get pregnant and maybe you could come off medications before, you want to try and do this in advance, because we would like you to be off medication, if you want to try coming off, 6 months before you become pregnant, so that we could see, are you going to remain stable once you've been off your medication? Is it going to stay calm, no seizures, or are they going to start coming back again? Because you don't want it all to start coming back again when you're in the middle of being pregnant. So that's why if someone becomes pregnant and they're on their medications, we do not usually recommend starting to switch medications around while the person's pregnant, because there's too much of a risk of having worsening of your seizures or adverse reactions to the new medication. So really, if you want to make changes, the time to do that is before you get pregnant. So that's why you have to sort of try and think ahead and plan and discuss it with your doctor in advance if you're thinking about becoming pregnant. So if you want to discontinue medications, usually we suggest someone has been seizure-free for several years before, 2 to 5 years. Usually someone would just have one type of seizure. Usually they would not have any. This just basically means like normal neurological development otherwise. And their EEG is usually would have to be normal on medication, because if they already had spikes, even if they're not having seizures, if the EEG is very abnormal, chances are if you come off medication, you're going to start having seizures again. And again, you should try and complete this whole weaning off the medication 6 months before being pregnant. This is what I said earlier, is that most women don't have a change in their seizure frequency during pregnancy. And if they do, there's several reasons that could be playing a role. So one could be the hormonal changes. Second is decreased drug levels. And so this actually becomes an issue, is that as pregnancy goes on, the drug level in your system drops steadily. And this is more of a problem for lamotrigine, but it's a problem for other drugs too. And this is due to, one, the blood volume is increased in your system so that your medication kind of gets diluted a bit, but also your body tends to excrete the medication faster from your system because the pregnancy sort of changes your metabolism. So as you get later in the pregnancy, the levels keep going down. And so you might actually have to keep increasing the dose towards the end of pregnancy to keep the level around the same that it was before so that you don't have seizures. People also sometimes don't really want to be taking their medication when they're pregnant, because you don't really want to take medication if you don't have to. So sometimes doses are skipped, and this might lead to more seizures. Sleep deprivation, of course, from being pregnant, and stress and anxiety also. So usually we have to monitor drug levels during pregnancy, and this is, I think, becoming more common or more accepted practice. It never used to really be done before, but especially for drugs like lamotrigine, which can be quite complicated during pregnancy to manage, even though it's sort of, okay, someone's having a question. Yeah, okay, what did you want to ask?
It's regarding lamotrigine.
Yeah.
To interrupt, but if you're on the highest level that you can take for lamotrigine and you've been told that's the best drug to be on,
Yeah.
if in your third trimester it's dropping, can you still take more?
Yes.
Okay.
Because it kind of goes on the levels in a way.
Okay.
So usually what we do is that before you get pregnant, if you're on a level that works for you, sort of get whatever your baseline level is. A trough level, in the morning before you take your pills, get the low level.
Right.
And then we see, okay, when she's doing well, her level is around whatever. And there's a wide range, but say for you, 13 or something is good.
Okay.
So then during the pregnancy, every month, every 2 months, we would do the level, and we'd see how it's dropping. And the studies have shown if it goes 25% below what it was, that's when the risk of seizures starts going up. So at that point, you probably should start. I've had people go to undetectable from 13, and because the level just drops so much with lamotrigine.
Wow.
And at that point, some people might not want to take more, but then you have a whole question about driving. Can the person still drive now that their level's undetectable in their system? That's another thing that comes up by doing this. So, definitely you can take more because it's based on the level. At that moment, your body's just getting it out of the system too quickly. And then right after you deliver, in the next week, the level will shoot right up again. So then you'll have to cut the dose back down, or else you'll get all toxic. So yeah, you definitely can take more. Okay, yeah, so basically said that. Okay, the fetal malformations. Okay, there's some new information on this topic, so about Topamax, which everyone seems to be talking about. So 2 main types of malformations that can occur with the fetus. The one is sort of the major congenital malformations. These are ones that would require medical or surgical intervention. So the most common ones would be sort of orofacial clefts, sort of cleft lip, cleft palate, cardiac defects, and then urogenital, like hypospadia. So it's problems with where the urethra places itself. And so women with epilepsy, general population is about 2 to 3% rate of these malformations, and it's about 4 to 6, and actually sometimes up to 7%. I think 7% is actually a better number in general for women with epilepsy. And then there's minor abnormalities where you don't really need to have a major intervention afterwards. So either small for gestational age or small babies, and then minor abnormalities like a webbed finger or things like this that are small. So factors that contribute to malformations. So besides the medications, if you have a lot of seizures during the first trimester, that has been shown to be associated with increased risk. Alcohol, drug use, obviously, malnutrition, folate, but other type, if you're really malnourished, that's obviously not going to be good. And genetics, if there's a family history of neural tube defects, that's also another big one. And diabetes also increases your risk. Also, in terms of the seizure medications, if you have higher dose of medication, and also the more medications you're on, the more chances you have of having the malformations. Also, specific drugs are more risky than others. And again, valproic acid is sort of the big bad one right now. These are the 2 that are more associated with the neural tube defects. So I added, this is a chart that talks about the incidence of the major malformations when a woman is on these medications alone, like just this one medication during pregnancy, not a combination. So any of them, it's around 7.8. But if you look at lamotrigine, carbamazepine, there's a range, of course, phenobarbital, phenytoin. If you look at valproic acid, it's much higher than all of the other ones. Just recently, this information, there's been two of the pregnancy registries, so the British one and then the North American one, came out with, one was in 2008 and one was just very recently, in the last months or so, with topiramate, looking at that. And actually, it's relatively higher than, say, lamotrigine or even carbamazepine. So this has actually prompted the topiramate to be degraded. Like by the FDA, it's now moved to a worse, scarier class, like class D of medication instead of class C, because now we have evidence that it does cause significant malformations. So I'll go into a bit more detail with that. These ones, we don't have any data on. So this is Keppra. Still, there's not enough numbers of women on Keppra alone yet to come out with the information. I'm sure it will come out soon because the numbers must be building for that. But that's the only reason why it's not have its own little category there. Lacosamide is very new, so we don't have any. And these two, not enough people, I don't think, have been using it, that it hasn't really been published either. So this is, as I said, for the topiramate thing, which is sort of the new topic that everyone's talking about. That only had 208 pregnancies, so it's based on this amount of patients. So 178 live births. So it's not a lot. It's not huge numbers. And so out of that, there were 16 major malformations. And most of these were the oral clefts and the hypospadias. But if you actually look at the numbers, even though it's small numbers, compared to the rate in the general population, it looked like the rate of the oral clefts was 11 times that of just the population if you weren't on this medication. And then the North America, and it didn't get much publicity, that one, because it wasn't really a large number, couldn't really draw too many conclusions from it. And just now, the North American Registry, it didn't even publish a paper yet, it's just an abstract. And it was presented at a meeting, and now it's led to all these things. But anyway, it's based on 289 live births, so more. And I kind of replicated those findings of the other study. So basically, it was 3.8% major congenital malformations compared to 1.3 in the group of people who weren't exposed to any seizure medications. And so when you compare it to, say, lamotrigine or carbamazepine, so the risk of having a major malformation with Topamax is 2.8 times that of the general population, 1.3 times for lamotrigine and 2.2 for carbamazepine. So it's significantly more than these two. And again, it's the cleft palate that seems to be the big thing, where basically its prevalence was 0.69 and in the population's 0.07. So again, it was 10 times higher than the general population risk. Also, there was more incidence of low birth weight. And that was also more significant, and there was no significant difference in birth weights for lamotrigine babies or carbamazepine babies. So it seems that the topiramate has a higher rate of oral cleft and low birth weight born to women on Topamax mono, just on that alone, versus lamotrigine alone or carbamazepine alone. But again, they said they still don't have enough evidence to show if it's a causal link, or there could be some other factors related to these women who are on only Topamax. Because they may not have had epilepsy. They could have, this registry, it's anyone who's on those medications. It could be for psychiatric reasons, it could be for headaches. So it's just the medication itself. So they couldn't control for all these other factors. But because of this, the FDA has made a new whole big warning about Topamax and about the risks of the cleft palate and cleft lip. And then, of course, there's the cognitive effects. Can the seizure medications that the baby is exposed to in the uterus then affect cognitive development, like IQ, later on? And a study was done that did come out in 2009 the results showing that when they looked at women who were either on Tegretol, carbamazepine, valproic acid, lamotrigine, or phenytoin, which is Dilantin, that only with the valproic acid was there a significant decrease in the IQ of the baby at age, when you looked at them up to age 3, after they were born, and they followed them till age 3. And so this was very significant. So it actually proved that valproic acid does have some cognitive effects on the baby. And the study will continue, and at 6 years, it's going to analyze the information again when the children are 6 years old. So that's also another reason not to put the women on valproic acid when they're pregnant, because not only can you have the malformations like spina bifida and cleft palate, but then you can also have these cognitive problems. Again, as you can see, lamotrigine's in there, but Topamax isn't in there, Kepra's not in there. So we still don't know information about those. But actually, sorry, there's just this one study that came out, this is very recent, like November 2010 or something, that compared valproic acid and Kepra, looking at the babies exposed to these drugs and looked at them up to 3 years. And actually, they showed that Kepra didn't have any effect on the cognition, and that valproic acid did. They sort of replicated the findings of the other study. So Kepra looks like it's probably okay too for cognitive development. But we don't have anything for Topamax or lacosamide. This is sort of like everyone gets this done. The GP will organize this. Everyone will get the ultrasound and discuss the other tests with you. So the neurologist and you don't really need to talk about those things too much, but just for your awareness. Let me keep going here because I'm taking too long. Okay, yeah, breastfeeding. Okay, so this is another topic that then comes up, and there's a lot of questions about it, but not a lot of information. So it's very difficult to actually counsel people on this, I find. All of our guidelines and all the information says that probably the benefits of breastfeeding outweigh the risks of the medication on the fetus. But we really don't know for a lot of medications. So if you really want to know the cold hard facts, there aren't a lot of them to really prove it either way. What has been looked at recently is sort of the amount of drug that's secreted in the breast milk. And in the recent guidelines that came out, they sort of divided the seizure medications into 3 groups based on how much is found in the breast milk. And basically the highest concentrations in the breast milk are levetiracetam, which is Keppra, and primidone, which is myceline, isn't used very much these days. So these would be the ones most concerning for potentially causing a problem. These were sort of middle of the road amounts, lamotrigine, Topamax, gabapentin. And then the valproic acid, carbamazepine, phenytoin, phenobarb, they are still secreted in the breast milk, but the amount is felt to probably be so small that it wouldn't be significant. So that's sort of a guideline, although we still don't have any proof either way. Except recently, the same group that was studying the cognitive effects of the valproic acid in the babies that I mentioned earlier, the NEED study, it also looked at, within their group of patients, children who were exposed in utero to these 4 medications, and then were breastfed with them as well, to one of these 4. And then compared those to the rest of them. The babies were exposed in the uterus but did not get breastfed. So they kind of separated them out. All of them would have been exposed to one of them when they were inside the mom, but then when they were born, some of them were breastfed, some of them weren't. So they divided those groups up and looked to see was there a difference in the cognitive development, well, in specifically the IQ. They just looked at the IQ. And it looks like there weren't any significant differences. So whether you were breastfed with any of these 4, it didn't look like there was any difference in your cognitive outcome. The effect on the cognition seemed to be related to the exposure in the uterus. So if you were exposed to valproic acid in the uterus, it has an effect on your IQ, but not these. And then if for breastfeeding, it didn't seem like any of these had any kind of significant effect. So that's a bit reassuring. And that's really kind of the best evidence we have for the breastfeeding. And really not much for Topamax or Kepa or anything. So, I mean, yes, it's possible we could find some more information in the future that's not good. But I think what's important to note is that the amounts in the breast milk in general are far less than what the fetus is exposed to in the uterus. So just because of that, you think it's probably not going to have as much of a problem. This then helps us. And we know that there's no major problems, like in terms of like babies dying, or sometimes they might get a bit sedated with certain medications, but there's no major kind of complications immediately from a baby being breastfed with the seizure medications. And then care of the child at home, that's another postpartum issue, sort of, which is also a difficult one to try and figure out how to best deal with. But it also depends on seizure frequency. So usually, I mean, the biggest issue is if the woman's at home and she has epilepsy and then she's tired and has a seizure and she's alone with the baby, or if she drops the baby, or if she's bathing the baby. So in general, kind of recommend that people do not bathe the baby alone if you have epilepsy. Changing the baby in general, kind of recommend that maybe do it on the floor, on a mat on the floor, rather than on a changing table or somewhere that the baby can fall off of, in case the mom has a seizure. And again, you know, checking in with people or having support, I guess, is the most important thing. I mean, you can't be, depending on how bad this person's epilepsy is, I mean, they may or may not need to be with someone all the time if they're having seizures all the time, or if they have rare seizures, you know, just need at least someone to communicate with, or kind of someone that checks in with them, especially when they're really tired at the beginning, you know, getting as much help as you can. Because obviously you're going to be more vulnerable to having seizures when you're really sleep deprived in the first couple of months. And again, so in North America, the only way we can get information about the effects of the medications on baby outcomes is by, you know, having people enroll in these studies. So this is for the North American. You can go on a website, the North American Pregnancy Registry, and basically the patient has to enroll themselves. The doctor can't do it. The patient has to call. There's a number, and they, you know, there's like 2 or 3 phone calls throughout like one during the pregnancy and one afterwards, or I'm not sure of the exact number but basically it's up to patients to register. So I try and remember to tell patients about this and give them this card, but I don't know how many people actually register. It's just another thing to do, but I think it's definitely worthwhile doing because that's the only way we can get this information. Okay, so I'm nearing the end because probably people are, I wonder if anyone knows what the hockey game score is, if anyone's checking their like Twitter accounts or what is it?
No, 1-0 for Canucks still.
Oh, okay.
Oh, really? Because on the text you read
2-1 San Jose.
2-1 San Jose?
Oh, no.
Oh, sorry guys. Everyone needed to know that update. Yeah, we have to score again. Okay, so I'm just heading into the home stretch here. So for the bone health, which is kind of this topic that bothers me because it came up and there was all this hoo-ha about it and everyone was like thinking this was going to be a big thing, and then it's kind of died off and not really much new information has come out. But basically, like I had said, that there was slightly earlier risk of earlier menopause in women with epilepsy, and menopause is a risk for osteoporosis. So if you're having menopause earlier, then there's a chance you could develop osteoporosis. It's more likely if you're having more years of menopause, or postmenopausal years, I should say. Also, if patients who have severe epilepsy, who don't move around, usually they have another physical handicap plus epilepsy. If they have decreased mobility, that's also a risk factor for having osteoporosis. And then there's the risk of the medications themselves. So there's several medications that have been studied and they have been shown to cause a decrease in bone density over time. but the exact mechanism of how this works is not well worked out. Each medication seems to have different ways in which they cause this problem. But one of the main mechanisms is that you get decreased vitamin D, and this is usually in the medications, the same ones that affect the birth control pill that induce these liver enzymes. So dilantin, carbamazepine, phenobarbital, benzos, so like this would be like Ativan or clobazam, and valproic acid also, and that one does not induce the liver enzymes, but it does definitely also cause a decrease in bone density. And so the decreased vitamin D, because of this liver enzyme kind of increased metabolism of the vitamin D, then you get less bone formation, because vitamin D is very important in helping form your bone. Now, so these are the ones that definitely have been shown to cause decreased bone density over time. And it's usually people have been on for more than 10 years. Definitely more than 20 years is where the risk really goes up. Definitely phenytoin, valproic acid are big ones, and phenobarbital.
What if you've been taken off of one of them, like
If you had been on it it depends how long you were on it before. Like if you were on it for more than, basically, I mean, what you could do is get a bone density test, so at a baseline. So if you know someone who's been on these medications for quite a while, even if they're young, it would be worth probably getting a bone density test to see if there's any obvious decreased bone density for that person. Even if they don't have a bone density test, if they're on these medications, you should definitely be recommending vitamin D and calcium supplementation at least.
What are the amounts that you suggest?
Yeah, the amounts. I'm getting to the amounts because they keep changing these amounts. So yeah, I do have a page coming up on that. In terms of other things, like more powerful drugs to help prevent osteoporosis, the endocrinology, which are the hormone people, they usually don't recommend these unless you're sort of had fractures already because of this. Because I had a patient where I asked this question. And so basically it's calcium, vitamin D, unless there's already some major evidence of osteoporosis or fractures that have already occurred, because there's risks to those drugs as well. So, and then there's also other factors in your life besides the seizure medication that could affect your bone density. So cigarette smoking definitely increases your risk of osteoporosis, alcohol. If you're on steroids for any reason, like prednisone for any other medical condition, this is if you're postmenopausal, or if for other reasons you have early menopause or an estrogen deficiency, low body weight. Asian women are more at risk than Caucasian, but Caucasians more than, say, African American. And then if you don't have enough calcium in your diet. So the most recent Health Canada recommendations, so this is for dietary intake. So this is for your whole day. So you're supposed to sort of factor in what you're eating and your supplements, which sometimes is difficult to do. But basically the vitamin D, it used to be 400 international units a day. Now they've kind of put the baseline to 600 international units a day as a minimum. The maximum upper limit is 4,000. Now the Canadian Cancer Society, for other reasons to prevent cancer, has recommended 1,000 international units a day. So 1,000 is definitely safe. And so I think most people are kind of saying 800 to 1,000 international units a day of vitamin D. Especially in Canada, we have less sunlight than, say, especially in Vancouver, let's say, compared to an equator country or something like that. So 800 to 1,000 would be a totally safe, pretty standard recommendation now. But you kind of have to factor in your diet, and for calcium.
On the bottom it said something about seniors. But I've never
Yeah.
heard that one before.
Well, this is according to the Health Canada. I just read this today. I double-checked before I came here.
Well, I thought it was maximum 800. No.
Minimum 800. So basically, once you're over 70, they suggest that instead of having 600 international units as the minimum, it goes to 800. So if you're taking, and 800 is perfectly safe at any age over 9. So 800 to 1,000 international units a day would be a pretty safe standard thing that most GPs would also be recommending now. The 4,000 is sort of the extreme upper limit. You know, I think most people, there can be dangers going above 2,000. So I wouldn't recommend anyone taking just every day 2,000, more than 2,000 international units. Because this is factoring in all your diet and everything. So as a supplement, 800 to 1,000 would be perfectly good and safe in our climate. And then the calcium, it's basically 1,000 milligrams a day, but you're supposed to factor in, you know, with your milk, your cheese, and all that kind of thing. And that's that. And yeah, that's the end of the bone health. So now questions, because now it's 8:30, and I've talked too long probably. Trying to make it interesting, but
I've got a question.
yes.
Have you heard of little to no hot flashes for menopausal women on AEDs?
So what do you mean, like that they don't get hot flashes?
And that if, for example, they were to go off the medication, they might experience
Oh.
hot flashes like other women who are going through menopause.
I mean, I don't think I wouldn't say that it's sort of like a well-known fact that women on seizure medications just don't experience them. I definitely know of people who have, even though they're on seizure medications. So, did you hear this from someone in particular?
I caught something last week. You know, don't think I caught the whole sentence, but someone was on an AED. They weren't an epileptic, but they had migraines.
Yes.
And because of the medication she's on, I guess maybe she assumed she's not having any hot flashes whatsoever,
Yeah.
where she was having them before.
So and when she started taking the topiramate, or an anticonvulsant, it helped. I mean, it could, as we said, some of them can affect the hormone levels slightly. So you never know in that person, maybe it reduced her estrogen or her fluctuations enough or minimized. You know, a lot of these medications can have other side effects and like pain modulation. So not that a hot flash is supposed to be painful, but sort of like a discomfort kind of like helps you tolerate things. So you never know with these medications, it may be having some other effect that's helping her tolerate it, or maybe it is minimizing. There's definitely not like some known fact about it. I'm sure there's individual cases. Yeah, I've never heard about it.
My other question regards valproic acid.
Mhm.
Everything I've read about it seems fairly toxic, to tell you the truth.
Right.
But it also seems to work really well. It does for me.
Right.
How long should you be on something like this before you start to worry about its toxicity? And maybe, starting to try something else.
Well, it depends what the toxicity you're worried about is, because I mean, if you're past the whole childbearing thing,
Nothing to do with childbearing.
because that's
General health.
general health. I mean, if it hasn't been affecting your cognitive function, see, people where it works for them, they feel great on it. They feel like their mind is actually sharper on it because they're not having this epileptic activity. I don't know if that ever happened. Anyway, I won't ask a personal question, but I don't think you should worry. The only thing that someone now would worry about would be the bone density thing,
Okay.
which you can kind of manage. So I think if that works for you, for the seizures really, really well, I mean, I wouldn't necessarily start switching it around. It's the bone density thing, I guess, would be the biggest thing at this point, because it's really the whole childbearing and fertility and kind of leading up to that where most of the problems lie. But once you're past that, I wouldn't really worry too much at that point, except for the bone density thing. Yep.
girls with epilepsy, is there any significant difference in regards to the age that they'll go through puberty, say later or earlier?
That's a good question. You might think that it would happen later if they're on valproic acid, but I don't have something specific in my mind. Like, I'm just speculating now at this point. I don't have a study that's in my head or anything like that. I would think it could interrupt the onset of it, because it tends to make you, if anything, have more anovulatory cycles, or not, you know what I'm saying? So.
What about in general, though? I'm talking about
Oh.
if you have epilepsy, whatever.
Oh,
condition.
epilepsy.
Is there any sort of significant difference?
No, there's no major difference. I mean, there might be, I don't even know if there's a study on that, but I would think that if there was a difference, it's not like going to be years or anything. It would be probably a year or difference max, or something small, nothing that's really major. Oh, someone, sorry. Yes?
With the bone density issues
Yes.
that are from, can that be a problem with the bone density?
Yeah, it's been shown to decrease bone density, but probably not to the same degree as phenobarbital, dilantin, or valproic acid. But it is there that it has been shown, so probably it's worth still being on calcium, vitamin D. But it's definitely not, in practice, it hasn't been as much of a problem. When I see people who have been on carbamazepine forever, they don't tend to have the same problems when I've checked bone density as, say, people with dilantin, phenobarb, or epival. Especially dilantin and phenobarb. They're really bad for the bone density. But, so I mean, it's I don't know if I'm answering your question. Yes, there's been proof that it does reduce bone density, probably not as bad as some of the other ones. If you're on carbamazepine, you should probably be on calcium, vitamin D supplementation. But probably most people, whether they're on seizure medications or not, should be on calcium and vitamin D supplementation, because we often don't get enough in our diet. Either way, yeah.
Any more questions?
I'll bring up a couple of things. What do you think about weight-bearing exercise and affecting the bones? Lifting weights and actually walking.
No, that's a very good point. Yes, so weight-bearing exercise is a good way to help increase your bone density. So walking, weight lifting can help, but it's more about bearing your own weight, kind of walking, running, that kind of thing, I think are very good. And
Some people will carry little 5-pound weights when they're
yeah, no, that would make sense, yes, because it's sort of about the weight that you're carrying helps to build the bone density. So yeah, if you can walk with little weights, but you wouldn't want to weigh yourself down too much. But yeah, no, that could be a very good strategy in addition to the calcium and vitamin D. Yeah.
One other thing that you didn't mention about seniors, which I experienced, was having a lot of side effects, going to a gerontologist.
Yes.
And being told as a senior, I don't need as much medication. And when I, on my own, just went down in the medication, some of these, I didn't have any problems with seizures, but the side effects went. Are you aware of that? That as you get older, your body
Yeah.
just doesn't need as much medication?
It can be the case that as you get older, also that the side effects become more of an issue as you get older. So if someone has seizures that are controlled, but they're experiencing side effects, it may be worth trying to reduce it at that point. It's sort of a matter of communicating and figuring out, is the person experiencing the side effects or not? Yeah, no, definitely an older person in general may not need as much medication as they did when they were younger. But if they're still having seizures, sometimes it's hard to know, can I reduce it safely or not?
I wasn't having seizures
Okay.
myself. They just side
Okay, well, yeah, no, that makes
Categories
sense.
So far came up and know what's going on.
Okay, no, that makes sense. Yeah, that it could be reduced. So then you had success when you reduced it.
And I what?
It was successful for you when the dose was
Yes,
reduced. Yeah, no,
yes.
so that yeah, no.
I did it myself.
Okay. Well, that's definitely, as you get older, it's something to think about, that doses may not need to be as high. But it's all a balancing act because the epilepsy might still be an issue.
Another-
Well, thank you, Dr.
Another
Townsend.
question I have before.
Oh, yeah. Well, just one more thing before, just about the geriatrics question there. So in general, if I'm starting a medication on an older person, we'd usually start at half the amount that I would start at sort of the average person on, because they can have, and I go up slower, because they can definitely experience more side effects when they're older. Okay, and then,
There was one question I was thinking, is that for a person, is it common for women to start going into menopause earlier in life than the average?
with epilepsy, yes. Well,
So-
studies have shown that yes,
And
that
then-
does occur.
Yeah, so what would be the age range for that?
Oh, well, the exact age, I think I had something written down about like,
4 years, I think.
it was like 4 years earlier or something like that,
Yeah,
so.
At the age 51.
Oh, very good. A few years before that. I knew 51 was there. I couldn't remember what I said. So, yeah, 51 is the average age. So, about 3 to 4 years before that might be when women with epilepsy might start going into menopause. Yeah, that's
I just have a question regarding increasing bone density. As you mentioned something about weight-bearing
Yes.
exercises and all that. I'm just wondering, have there been any studies in North America regarding vibration therapy, i.e. through power plates and that kind of thing, with increasing bone density?
I'm not aware of that. I have never heard of that, so I don't know. Yeah.
What is it? What is vibration therapy?
Well, I was part of a study in the UK where there are these new things called power plates, which are supposedly craze in gyms and such, where it's essentially
okay.
just a vibrating plate, which is intended to mimic weight-bearing exercises
Oh,
or
okay.
something like that if you're unable to do so.
Mm-hmm.
So just the idea of mechanical stimulus on the bones, increasing bone densities.
There might be something on. I mean,
I think it's still in the ground
Yeah.
stages, but perhaps in the future.
yeah, maybe some. Could look it up next
All right,
time.
well, one more?
Well, so bone density can
Yes.
be, or the test can be done as early as what? Because
I know,
the
there's-
test does not.
They won't always pay for it. It depends because there's indications. You kind of have to have more. Being on seizure medication is one possibility, but you have to have something like 2 of these indications. So there has to be something else, like you're at high risk for some other reason. So depending on what the doctor checks off, you may or may not get it covered. But the best way to compare with yourself is to kind of have a baseline and then be able to compare with yourself later on. So
Do you have seizure medication if you have a
it's,
parent or
yeah, something like that, or your
hospital?
weight, or if you're, there's a few different categories on the requisition for that, or else you may have to pay for it. But there's no lower, I mean, you could still have it done, it's just someone might have to pay for it if you didn't meet all the criteria.
All right, well, I think we've learned a lot about issues pertaining to women's health, whether we do have epilepsy or we don't, particularly in the different lifespans. I think a lot of times when you used to hear about women in epilepsy, everyone thought pregnancy. It's like, no, we have to look at, the entire woman, from the beginning through puberty, through menopause, etc. And like I said before, all of us with epilepsy are unique. And some of us with epilepsy do have additional concerns or things that we might want to look at. And the best way to kind of keep up to date is to continue educating yourself, such as coming to this lecture, keeping up to date with the reputable and kind of peer-reviewed information and research. We want to make sure that you have the best information to care for yourself and for your loved ones. Thank you very much, Dr. Jensen.
Thanks.